Welcome to the PhysioNexus Biomechanics series. My name is Dr. Trent Harrison. This video, we're going to go in depth on the wrist. If you want to jump ahead to any particular sections, these timestamps should let you know where you want to go in particular. The importance of the wrist, general look and design, basics of wrist mechanics, muscle and ligamental concepts, flexion, extension, the rows, they're not pretty, so it's Henke's principle, sagittal stability, adduction, abduction, Conwell's simplified explanation, and then finally my closing thoughts and comments. Let's go ahead and go into the importance of the wrist. Before we dive in, let's discuss the role of the wrist and why it's so important. If you think about the upper extremity, the shoulder, it gives us a great deal of movement and freedom. The elbow, it's going to allow us to move objects away and farther, closer and away from our body. And then the forearm allows you to manipulate the hand and the approach of the hand to a target by bringing in that rotational component. So the motion that the wrist provides isn't necessarily about movement. It doesn't add a whole lot comparatively to what we've already accomplished with these other joints. What it does do, primarily, it allows you to control the length-tension relationship of the muscles that are going to be gripping and grasping and performing delicate pinching. You see, the muscles in the hand are more designed for control, balance, not necessarily torque or force output. So playing with their length-tension relationship, well, that allows you to maximize this output. You know, we've all felt it when you've tried to extend the wrist while trying to grip an object, or you're trying to ulnarly deviate it and get that extra little ounce of power. But how does it function? When we look at an x-ray, it's just these bones look like a sack full of marbles. Well, let's take a look at the joint surfaces and the structures, and we'll go from there. Also, if you're new to these videos, you're going to need a couple items: pencil, preferably multiple colors, and a large piece of paper. We're going to do a lot of drawing to try and make sense of all this. All right, so let's go ahead and get started. General look and design. We have the radius here, and we also have this radiostyloid and this concave surface that you can see. Next to it is the head of the ulna with its ulnar styloid. The ulna is not as distal as the radius, so we'll see why in the biomechanics of the forearm when we get there. What then takes up the space between those is the TFCC, or the triangular fibrocartilage complex, which is technically TFC since fibrocartilage is one word, but I didn't name it. So that's going to be in between the carpals and the ulna. Next, we have the proximal carpal row. This is the row that's designed more for mobility, not only as a group, but even amongst the carpals themselves. After that, we have the distal carpal row, which is much more rigid. We have a tighter joint surfaces here between them. Separating this out, let's go ahead. We have the scaphoid, the lunate, the triquetrum. Then distally, we have the trapezium, the trapezoid, the capitate, and the hamate. And then floating around here somewhere is about the pisiform. Now this makes up the radiocarpal joint here, and this would be the midcarpal joint. Now this is a stylized drawing, and it's on purpose, and I'll show you why now. So we have convex and concave surfaces, and we have concave on convex surfaces. You see the radiocarpal joint, it's all convex on concave. And the midcarpal joint, well, let's divide it up. This is sometimes described as a lateral or medial parts or columns, and thought of almost as different structures. Obviously, this is going to be relevant later on when we get into the mechanics. Also, it's important to note that the head of the capitate is sometimes thought of as the key structure here, because it's also known as the keystone. It's cited in some literature as the axis of motion for the wrist, but this is not fully agreed upon. You actually have a lot of debate on if there actually is a uniform way this area moves, or if each person individually has small deviations. The capitate is convex on all sides, like a pebble, and its relationship with the lunate is that it allows the lunate a lot of freedom and movement, particularly in deflection extension. The proximal row was described earlier as mobile, or less rigid, because it gives rise to motion between the radius and the distal row. But this also means that with increased laxity in the ligaments in this area, you're going to be much more susceptible to displacements or subluxations. Now this image shows these surfaces as very symmetrical also and very congruent. But in fact, the radiocarpal joint typically only has about 20% surface contact with the proximal row, which gets up to about 40% in certain situations. So this joint incongruency, in addition to the angles provided by the radius, which we'll see soon, This adds for greater possibility of range of motion. If we want to further detail in our illustration, we can place a small groove here since the radius technically has two facets that contact the scaphoid and the loop. So that gives us the basic structures of the joints themselves. So let's back out to what the wrist can actually do. It's a two-axis joint moving into the sagittal plane, flexion, extension, and also into the coronal plane, abduction, adduction. All of the rotational movement, well, that comes from the forearm. It's going to be the forearm moving you into pronation, supination that adds that extra motion. The wrist has about 85 degrees of flexion, but you can get up to 90 plus if the forearm is pronated. And it has about 85 degrees of extension, which can go 90 plus if the forearm is either pronated or supinated. Now, radial deviation, that's roughly about 15 degrees actively. And ulnar deviation, that's about 45 degrees actively, but this decreases to about 25 to 30 degrees when the forearm is actually pronated. Now, all these deviations were from forearm manipulation, and the wrist itself was still in a neutral position. It's important to note that as the wrist moved towards any of these bidirectional movements, it loses out on some of that range of motion. Also, the key position for function has been shown to be slight extension, about 20 degrees, and about 10 degrees of ulnar deviation. This position places the long digital flexors in a spot of sort of maximal force generation for grabbing and gripping. It's important to make a quick point about muscles in general, also before we get into the motions themselves. You see, most muscles are not pure motion muscles. They don't just pull directly and only into one of our planes of motion, sagittal, coronal, transverse. Because of that, when we do pure plane motion, we need to have multiple muscles working synergistically. So if you wanted to do sagittal plane, for instance, at the wrist, we'll say extension. That would take using a muscle that does both extension and radial deviation, and a muscle that does extension and ulnar deviation. Hopefully then the ulnar and radial deviation components will cancel each other out, and what you're left with is the motion that you actually intended. Of all these wrist muscles, it's also interesting to note that there's only one muscle that attaches to the proximal row, and that's the flexor carpi ulnaris. But technically it attaches to the proximal row, but it attaches to the pisiform, so it almost doesn't count. The implications is one of stability. So now that means that the proximal row has less muscle activation to assist in its control, which means that it truly relies on that ligamental system for support. The ligaments, from a large perspective, can also be categorized as intrinsic or extrinsic, with intrinsic being interosseous or directly between different carpals, and the extrinsics kind of spanning across surface, maybe multiple carpals. Now, the intrinsic are dealing with less force, but they also rely on synovial fluid for nutrition, since they are intercapsular, whereas the extrinsic take on greater forces but have more reliable means of healing. Looking at the motion of flexion, we have the flexor carpi radialis, flexor carpi ulnaris, and the occasional palmaris longus. Now, all the finger flexors can also assist with wrist flexion, but we are currently discussing pure wrist flexion because we're going to leave them out. Once the fingers get involved, you actually drastically limit your range of motion, because when you flex your fingers, the tension of the finger extensors on the other side, they're going to limit the ability of the wrist to flex, and vice versa. The finger flexors are going to limit your wrist extension. Now, the FCU and the FCR are designed to help counter each other. FCR runs separate from the carpal tunnel in a special little groove deep to the flexor retinaculum, and it inserts on the second metacarpal and reaches a bit to the trapezium and the third metacarpal. It's going to perform wrist flexion and radial deviation. FCU passes the anterior ulnar styloid process and inserts into the proximal surface of the pisiform, parts of the flexor retinaculum, the horn of the hamate, and the fifth and fourth met bases. It's thought that the sole purpose of the pisiform, since even though it's a part of the proximal row, it has no articulations in that sense, is to increase the moment arm of the FCU, making it much more functional. The palmaris longus attaches to the retinaculum and sends 4 bands into the palmaris aponeurosis. The tendon of this muscle can help with scaphoid stability, which is more of a factor during extension of the wrist, so we'll get to that. So what occurs now at the joints during flexion? Well, you get a volar roll and a posterior glide of the proximal row on the radius. This radiocarpal joint comprises about 50 degrees of the 85 degrees of total motion. Now, these degrees are also extreme ranges only. Typically, these two joints, the midcarpal and the radiocarpal, are going to move equally until you get higher in range. The midcarpal there in the total range is going to only accumulate about 35 degrees. Now, there are different mechanics here. The capitate and the hamate will do the same as the proximal row. They're going to roll anteriorly but glide posteriorly. However, the trapezium and the trapezoid, being concave on convex, they're going to roll anteriorly and glide anteriorly as well. Now, what will stop or guide this motion? Let's get into the ligamental structures as they pertain to flexion. During flexion, it's mostly the posterior radiocarpal ligaments that are active. These dorsal ligaments are considered thin in respect to the anterior counterparts that are considered much thicker and stronger. This posterior radiocarpal ligament complex, it's positioned at what would be the exit points of the axis of motion for abduction-adduction. There are two primary bands to visualize here. You have the posterior radiolunate band, which is sort of the break of the lunate itself, and the posterior radiotriquetral band. This is the posterior half of what's going to be known as the triquetral sling. And we'll get to that when we get into that coronal plane. Now, there are other ligaments located in the posterior hand that run transversely and from carpal to carpal, but these two just mentioned are the primary restraints that tighten up during flexion. It's also important to note that the extensor carpi ulnaris is active during wrist flexion. It tethers into the TFCC, and it's thought that it provides additional stability to the less stable ulnar side of the wrist. Moving on, we have the extensor tunnels. Compartment 1, extensor pollicis brevis, abductor pollicis longus. 2, the extensor carpi radialis brevis, and the extensor carpi radialis longus. 3 is the extensor pollicis longus. 4, extensor digitorum, extensor indicis. 5, the extensor digiti minimi, and 6, the extensor carpi ulnaris. We'll be talking about pure wrist extension, and so the only muscles relevant in these compartments are ECRL, ECRB, and the ECU. Now, it's important to note clinically that the finger extensors can perform wrist extension, but when you use those muscles, you have a limited total range of motion, and this is due to the finger flexors during the extension motion. The tension of them will limit the available range. So, ECRL is an extensor and a radial deviator, and the ECU is an extensor and an ulnar deviator. And the ECU passes the ulnar styler process, very strong fibrous sheath, and it inserts on the posterior aspect of the fifth metacarpal base. ECRB, it's actually considered to be a pure extensor, so functionally it's very, very important to have that active. It runs with the ECRL along the snuff box, and the ECRB is going to attach to your third met base, and the ECRL, it goes over to the second met base. And the ECRL, from this angle, you can see the radial pull of it. As you go towards that 85 degrees of extension, 35 degrees is only going to come from the radiocarpal now, whereas 55 comes from midcarpal. The reason is that in this case, the midcarpal joint is more mobile technically than the radiocarpal because of the shape of the posterior radius. Posteriorly, the radius is more distal than the anterior, and the proximal row runs into the radius, and it brings that motion to a halt. Now, during this motion, it's the opposite of flexion. The proximal row will roll posteriorly and glide anteriorly on the radius and the TFCC. The hamate and the capitate will do the same on the triquetrum and the lunate. And then the trapezoid and the trapezium, due to their concave nature, are going to move on that scaphoid posteriorly with a roll and glide posteriorly as well. During this motion, we now have the anterior radiocarpal ligaments that are acting as restraints. The two major ligaments here are the anterior radiolunate band, running obliquely, inferiorly, and medially, and attaches to the anterior horn of the lunate, and is the anterior break of the lunate. There's also to be noted a ligament called the anterior ulnolunate ligament that acts as sort of a support or a supplemental support for this previously mentioned ligament. Now, the second ligament is the anterior radiotriquetral band, the other half of that triquetral sling. Now, there are lots of other supporting ligaments from each carpal to carpal, like we mentioned before in the posterior aspect, but those are the primary ones we're talking about. Now, the rows aren't pretty, like we said. This is talking more about Henke's principle. So if we think about those planes of motion, we already talked about how the muscles don't move in a perfect plane. Well, the joint surfaces aren't perfectly lined up as well. They're not perfectly lined so that the sagittal plane is exactly where they're moving and the coronal plane is exactly where they're moving. And so all of these small bones are going to be moving independently and in odd little motions. Henke's mechanism is at play here, where once again, you have in essence counteracting motions. So technically the proximal row has a pronating motion to it, meaning that during flexion, it's going to flex, but then the whole row abducts and pronates a little bit on the radius. And the distal row is going to be supinating, where as it's flexing, it's actually adducting and supinating. And then hopefully these abduction and adduction and this supination pronation mechanics will cancel out, and the end result is flexion. Now, the opposite's going to happen with extension, and you don't have to memorize this. The key idea is that this is not a perfect little gear, in essence, that's going to be moving on a specific track. There's a lot of extra play in here, a lot of extra motion. Now, it's important now to discuss where the wrist is more and where it's less stable between flexion and extension. This has to do primarily with the shape of the distal radius and with the pull of the muscles. When the wrist is flexed, the muscles tend to approximate the joint. They pull into the radius. At the same time, the posterior ligaments are taut and also pulling the proximal row, and that lunate in particular, back into the joint and approximating those surfaces. A flexed wrist is therefore a little bit more stable in this sense. Now, when an extension, the proximal row is technically on a slant, and the pull of the muscles accentuates this slanting force and therefore makes it less stable, as the carpals want to sort of escape proximally and anteriorly. In this position, the ligaments are highly needed to keep stability. Tension from these anterior lunate and capitate ligaments are much more needed to drive them posteriorly. When discussing the lunate, you have to also understand the relationship it has with the scaphoid and the triquetrum. Between each are ligaments, and those ligaments in essence anchor the lunate in place. If you have a disruption of the scapholunate ligament, for instance, it's going to result in what's called a dorsal intercalated segment instability, or a DISI. And the same goes with if you rupture the lunotriquetral ligament. Then you're going to end up with a volar intercalated segment instability. Those terms we'll go into more when we get into the pathology video of the wrist and hand. In terms of the lateral pillar, meaning the scaphoid, trapezium, and the trapezoid, you have a different scenario. The scaphoid, it's kind of an odd-shaped bone. You can see how it's almost kidney bean-shaped. When you go into flexion, it kind of lies down, becoming flatter on the radius. And the trapezium, and the trapezoid, they're going to move towards the radius and kind of cover it up. However, in extension, the trapezoid and the trapezium, they're going to move posterior, and the scaphoid gets pulled into a standing position, which is a little less stable. The primary restraints now are going to be the radioscaphoid ligament and the scaphoid trapezial ligament and the scaphoid capitate ligaments to help kind of push it back. Now, there's going to be secondary restraints like the radiocapitate ligament that run across it but don't actually attach to it. And then the third option for restraint would be the palmaris longus tendon, like we mentioned before. The individual who actually has one, when they contract that muscle, that's going to act as sort of a strut or a band. Now, the scaphoid pillar should lock before the lunate pillar. The lunate continues to move into extension about 30 degrees more. If the scapholunate ligament wasn't so elastic in its nature, this wouldn't be able to occur. So that covers the sagittal plane. So now we can look at the coronal plane and how motion occurs here. The muscles responsible for purely wrist adduction are going to be your flexor carpi ulnaris and the extensor carpi ulnaris. Together, they should cancel out the flexion extension portions of motion, leaving you with just adduction. It's a fairly stable position. As you move this way, the proximal row will roll medially and glide laterally, and this motion gets checked by the radiocollateral ligaments. They're attached to the radiostyloid and the scaphoid. Now, one of the reasons it's a more stable is that when you look at the shapes of the radius, once again, like flexion, the muscles are increasing the coaptation forces of that proximal row into the radius. Now, like flexion extension also, there are a lot of movements going on in these carpal bones that you have to be sort of aware of. Of note would be that the lunate comes to rest on the radius, which technically would be a little bit more stable of a base. The trapezoid and the trapezium, they're going to move medially and distal to the row of the scaphoid, which means that the scaphoid is going to kind of stand up again like an extension. And then the hamate kind of comes down and it has a proximal portion that comes in contact with the lumate, once again acting as a little bit more stability. Abduction is not considered as stable as adduction. The muscles performing the action, ECRL, ECRB, and FCR, they're going to counteract their extension and flexion to cause pure abduction. Now, it's been shown in electrical stimulation studies done that it was the ECRB is pure extensor, like we mentioned, and it showed that the FCR didn't do much abduction. The ECRL was your primary abductor by far, and the FCR was almost more just there to counteract that extension moment that the ECRL had. One problem we run into here is the radius is distally longer laterally, causing a slant, once again, that the muscles are going to be pulling the carpals down. This is similar to extension. Now the lunate is now moving over to the TFCC, and it's kind of in between resting the radius and the ulnar, so that's not as stable. One restraint to stop an issue with abduction is the ulnar collateral ligament. This runs from the styloid process to the triquetrum and the pisiform. Next, the body has developed the triquetral sling just for this scenario. And we talked about this before, that you have the anterior and a posterior radiotriquetral ligament, and together they create this sling. They're going to work together to kind of pull this proximal carpal row more radially and to avoid sort of possible dislocation here. Now, some articles or textbooks might also describe these two ligaments instead as the radiolunotriquetral anteriorly and the dorso-radiocarpal ligament. It's just important to know what their functional means is. As a quick side, let's talk about rotational forces and how they're distributed. Now, we already talked about this being a two-axis joint or a universal joint, but it still has to deal with rotational forces because pronation and supination through the forearm while gripping an object turn or cause a lot of forces to cross into the transverse plane of those carpals. And this is dealt with by all of the ligaments that are sort of in this supporting system. You can see that most of them are running posterior and anteriorly and oblique at odd angles, and also sort of transverse. Anterior ligaments run sort of proximal to lateral to deal more with supination, and the posterior ligaments run a little bit more proximal to medial to deal with pronation. So in addition to this, you have all your interosseous ligaments of these carpals that are going to prevent dislocation of these individual motions. They're going to check excessive gliding, for instance, of the scaphoid relative to the lunate and vice versa. If you're gripping an object, you're activating your flexors. It's been seen that flexor tendons act sort of like a catch or a clutch and will reduce any sort of rotational drift or movement between carpals by as much as 20%. So Conwell's simplified explanation, this was a gentleman named Conwell who had a very dry cut way of describing motion. So if the wrist is in full flexion, activating the extension is going to initiate the distal carpal row. And this is done by wrist extensors that attach to the metacarpals, and those are bound tightly to the distal carpals. The distal carpals are going to glide relatively fixed proximal bones. He states that it's an odd shape of that midcarpal joint, but the distal carpal row effectively glides the same direction as the hand. Okay, when the wrist becomes neutral, the ligaments attached to the capitate and the scaphoid are going to tighten up, and they're going to become sort of a pair. And the extensor continues to generate force and move now this distal row and scaphoid as a unit around a fixed lunate and triquetrum. At about 45 degrees, the scapholunate ligament now tightens up and the scaphoid and lunate become closed packed. And at this point, the carpals are considered a closed, tight unit. Completion of wrist extension then is the radiocarpal row moving on a fixed TFCC and radius. And all the ligaments become taut at full extension, and you have a fully closed packed system for the wrist. Not necessarily closing thoughts on the wrist itself. I think the wrist is a fun area to treat. Personally, we don't get a lot of them, obviously, in physical therapy, but in occupational therapy and other areas, you get to see a ton of them. I enjoy the biomechanics, especially a lot of the manual techniques. When it comes to these videos, please leave comments down in the section. Please join us over at PhysioNexus, and eventually the Patreon page will be up and running. And I hope to see you soon in some of our future videos.